Good morning, everyone. This is PD Active's speaker forum. If you are on right now, that's where we are. And we're going to give folks another 1 or 2 minutes here to log in, and then we'll get started. Okay, it's 11:04, typically when we like to get started. So good morning, everyone, and welcome to PD Active's 10th virtual speaker forum. My name is Todd Morrish, and along with Monique Buffler, say hi, Monique. We will be your hosts and moderators this morning. Before we introduce today's speaker, a little bit of housekeeping. First, the PD Active Board and the PD Active Diversity, Equality, and Inclusion Committee welcome your input and involvement in ways that will help increase the diversity of PD Active and help address the healthcare disparities for people of color with PD. In short, we want to connect people of color struggling with PD to the many wonderful programs, classes, and events that PD Active offers. You can help us by connecting us to people you may know at community health centers and other community-based health programs in Alameda County. If you have experience in this field of work, let us know so we can tap into your knowledge. Please send an email to this address to express your interest. That's administrator@pdactive.org. And Monique, if you wouldn't mind starting that copying and pasting into the chat window, that would be great. Next, and speaking of those wonderful PD Active programs and classes, we always like to take a moment here to cross-promote those. Besides PD Active's highly regarded support groups, we also offer Tai Chi and yoga and Pilates and meditation. And there's voice and singing and boxing and dance and much more. If you have tried one or more of these, we ask you to please tag a friend or family member to join you on your next session. Please check out the calendar link on the pdactive.org website, and we'll paste that URL into the Zoom chat tool now as well. One important note, this webinar is being recorded right now. So thank you, Dr. Brillman, for allowing us to do that. We will post that recording to our PD Active YouTube channel in the next few days, probably more like 1 or 2 days. And again, see the chat window now for that URL. Throughout our presentation this morning, we will present you with a handful of poll questions, which will pop up on your Zoom screens. Please answer these as quickly as you can so Dr. Brillman may respond to these in the flow of her presentation. If you prefer to not answer the questions, merely close the windows when they pop up, that's fine. We will start with one quick question right now so that Dr. Brillman can understand her audience. So give me a moment while I throw one of those up there real quick. This is how that looks. I'll publish the results in one moment. Finally, PD Active depends on donations to bring events like this to our members free of charge, and we remain grateful for your contributions. If you have not yet had a chance to make the suggested registration donation of $10 for this forum, we will paste that link into the chat feature now as well. And that button can always be found on pdactive.org as well. Big donate button. If for any reason any of the three of us gets disconnected from this webinar, which I highly doubt, please be patient and do not disconnect or leave the meeting for a few minutes as we try to get reconnected. It is possible that Monique may take over as host if I am disconnected. Okay, here we go. PD Active is thrilled to have joining us today Dr. Salima Brillman. Dr. Brillman's CV is impressive. A board-certified neurologist with a fellowship in movement disorders, which includes Parkinson's disease, atypical Parkinsonism, drug-induced Parkinsonism, which I didn't really know was a thing, essential tremor, dystonia, Lewy body dementia, and other neurodegenerative disorders. Upon completion of her medical studies in 2006, she pioneered the development of the only deep brain stimulation or DBS program in North Dakota, where she also was on the faculty of University of North Dakota. In 2015, she and her family moved back to her native California, where she became the director of the clinical care program at the Parkinson's Institute. Finally, she founded the Parkinson's Disease and Movement Disorder Center of Silicon Valley in December of 2017. If I'm getting any of these wrong, by the way, Dr. Brillman, you need to correct me on when you introduce yourself. She founded the Parkinson's Disease and Movement Disorder Center of Silicon Valley in December 2017, where you still are today, I believe.
Correct.
Where it is her vision to offer patients and their loved ones a healthcare model that prioritizes and sets forth a practice focused on improving quality of life. Hallelujah for that. Dr. Brillman provides patients and their families the opportunity of having individualized healthcare where third parties like PPOs and HMOs do not set the time and frequency of clinical visits. Recognizing this need for comprehensive and continuous care for people with movement disorders, Dr. Brillman became one of the first, and I put this in quotes, concierge movement disorder neurologists, unquote, mostly because I had never heard of that term. In the Bay Area, seeing patients in her office via telemedicine or even in their homes. Today, Dr. Brillman will walk us through a slide presentation, and we expect to reserve at least 30 minutes after that for questions and answers. Please submit your questions via Zoom's Q&A feature, which you'll find in the lower tool tray of your Zoom window. Monique and I will use Zoom's chat tool, as you've seen, to deliver information to you, but we ask you to submit questions to us through Q&A. Dr. Brillman, welcome. Sorry for the long-winded introduction, but thank you very much. I'm sure I'm speaking for all of us and thanking you for taking time out of your weekend to speak to our community. And I'll hand the figurative mic over to you now, and please take it away. Let me actually start by ending this poll, and I'll publish right now so you can see who you're talking to.
Okay, great.
Take it away.
Wonderful. Okay. Great. Well, thank you so much. Thank you for inviting me. I really appreciate the invitation, and I appreciate everyone's time, and I hope that it will be fruitful and you'll learn from this. And I hope that you'll have questions and pose those questions for me. I am a very big advocate for learning and education in Parkinson's. I think there's a huge gap. And of course, practitioners in this day and age of medicine don't have the time, and some maybe don't have the will to educate their patients, but I hope that you'll find this interactive and educational. So please pose the questions if you want to. So I'm going to just give a little introduction about PD, which I'm sure you all very well know what PD is. Am I doing the
Yeah, let's have you share screen if you would. Let's start with that.
Okay.
You can grab your keynote, or if you'd like me to, I'm happy to do it and you can guide me, your choice.
You can do it. Oh, no, I'll do it. That's okay. Sorry.
Yeah, whatever's easiest for you.
Okay. Oh, you know what? No, you go ahead, Todd. Sorry about that.
Not a problem. I've got it open, so hang on, let me put it into presentation mode here.
So as you know, today's discussion is about dyskinesia and gait, and definitely not neither together or separately or how they interact, but we're going to get through the whole thing. I think dyskinesia is a really important, both are very important topics as they affect people with PD. So starting off with what Parkinson's is. So as you all know, it is a neurological condition that affects the neurotransmitter dopamine. And So by the time a person has any symptoms, motor symptoms of Parkinson's, they've lost about 50 to 80% of their dopamine producing neurons. And that translates into slowness, stiffness, and in some people, it can translate into to tremor as well. So when we treat people with Parkinson's, our goal is to increase their dopamine. Now, why do some people get it and some people don't? Well, the reality is we don't know. We don't know why some people do and others don't. We think it's a combination of genetics and environment. It's not all one or the other, likely a combo of both. Next slide. So quickly, and you all, I'm sure, being part of PD Active, know very much about the motor symptoms and the non-motor symptoms. So I finished my fellowship in 2006, and we've learned so much about not only the motor, but the non-motor symptoms of Parkinson's. And so as you can see here with this list, it's vast. So just as an aside, so tremor, doesn't happen in everybody with Parkinson's, and 30% of people with PD don't have tremor and never will. But the cardinal signs are tremor, at rest, stiffness, slowness, and then postural instability or falls. The non-motor symptoms, so constipation, loss of sense of smell, sleep issues, definitely. So people may have REM sleep behavior disorder. That's when they act out their dreams. They may have restless leg syndrome. They may have insomnia. Some people may sleep too much. And then, of course, there are people that have anxiety or depression. They may have hallucinations or delusions, cognitive issues, pain. And this whole list goes on. And that's not to scare anybody. And it's not to say everyone's going to get everything. I put this up because I think it's important that people are educated to the fact that this may happen, these may happen, and one should bring it to the attention of their physicians so that we can help, because we have so many tools now to help people with their symptoms. Like of course, we don't have any cures at this point, but we do have a lot of really good symptomatic treatments to help many of these symptoms and make your quality of life better. And that's the absolute goal in treating people with Parkinson's today. Okay, so what can we do about it? We have pharmacological and non-pharmacological treatments. And so the pharmacological ones, which we'll get to in a moment, the non-pharmacological ones, as you know, very, very well. Exercise is absolutely, it's crucial in people with PD, keeping your mind sharp, socialization, eating well, those kinds of things. So moving on to the pharmacological treatments. We have many treatments in helping people with Parkinson's. And these are the general classes that we have to increase indirectly or directly a person's dopamine. Because remember, the fundamental problem in motor and even non-motor is this loss of dopamine. So what we try to do is increase that dopamine. And we have these classes: levodopa, MAO-B inhibitors, dopamine agonists, Compt inhibitors, and then the newest is istradefylline. You may know this as Neurogenic. So levodopa, and there's many forms of all of them. Levodopa is the oldest one that we have. It's the gold standard. And then the MAO-Bs, what they do is they help to decrease the breakdown of our own dopamine, as well as the pills that we take, or if we use an intestinal gel. Dopamine agonists, you may know those as either Miralax, pramipexole, which is the other name, ropinirole, or Requip, and then there's the transdermal rotigotine patch. Now, in the past few years, we also have medicines that help with on-demand. So if a person is in an off, you can use things such as an inhaled levodopa or a short-acting dopamine agonist, like a subcutaneous injection of apomorphine or sublingual apomorphine. So there's so many ways to treat symptomatically people with Parkinson's these days. It's so vast now. We've had, like, I want to say 9 new medicines in the past 8 years. So many things. Compt inhibitors, they too prolong or extend the use of levodopa as well.
And Dr. Brillman, what does Compt stand for?
It's Compt is oh, you got me there. It's a chemical. I don't remember the exact. So it's a COMT inhibitor.
It's okay. We'll look it up.
Yeah. It's one of the things that breaks down the dopamine peripherally and centrally. So, and then a decade and a half ago, we had Stalevo or Comtan, and now we have the newest one, which is opicapone, and that's once a day, and that just came out like last year. So there are lots of different things that we can use to make the day better. For those of you who've had PD for a long time and you were in the era of just levodopa or the dopamine agonists, there's so many different ways now to treat, and it's really an art, and it really is, it should be based on that person and what those needs are for that person. Okay, so next slide. So levodopa is the gold standard in treating Parkinson's, even though we have all these other things. It's the closest thing that we have to our own dopamine. And I think it's important that this is a really important topic, because I've had so many people say to me, well, I'm afraid of dopamine. I don't want to use levodopa. I'm afraid I'm going to get side effects in the future. And I think this is an important topic to broach, because the pendulum has really shifted. People used to think, well, if the person is young, we should wait, et cetera, et cetera. And we know things that are different now based on certain studies, based on how people were treated with the amounts of levodopa, et cetera. So are we taking the poll right now?
We are here. I'll publish it for you.
Okay.
I saw that one of your bullet points was when it should be started, so I thought I would put this up now while you were chatting.
Yeah. Oh,
So,
wow.
like
Okay.
half respondents were inside of the first year of diagnosis.
That's great. 5 to 10 years. Wow. Okay. And it would be interesting, yeah, to know what the ages were based on that, because some people will say, well, I'll just wait. And I've even had a patient who was like 85 say, well, I'm just going to wait. And the question is, you want to be the best you can be now. We want you to be the best you can be, but we also know that we don't want to just keep upping and upping and upping the medication or the carbidopa levodopa to the point at which you have side effects, either in the short term or in the long term. So those are the lessons learned now. Way back 20 years ago, that wasn't the case. Back then, people thought, okay, we'll just, if you're younger than 60, we'll hold off and we'll save it for later, and we'll give you a dopamine agonist. And anyone over 60 or 65 will get levodopa. But that's the pendulum that's changed now. And we don't want people to be afraid of levodopa, because it really can improve not only your life today, but also prognostically later. Next slide. So that leads me to what people can and have been afraid of, and that's dyskinesia. So what are dyskinesias? So dyskinesias are an involuntary movement of a certain part of a person's body. These are or can be induced by levodopa, but they can also be induced by anything that increases your dopamine. What we know it as is levodopa-induced dyskinesia. So that's what we're talking about here, levodopa-induced dyskinesias. And typically, this will happen. There's certain risk factors. So it happens typically within in 5 years or so, but there's risk factors in that if you take a lot of levodopa, meaning over, say, 300 milligrams per day, if you are young, if you are a thin woman, those tend to be the risk factors. The longer you have the disease also can lead you to that. But we've seen studies that even those people who have waited, they'll still get to the point of dyskinesia at the same time. So there's no sense in waiting for the use of the levodopa. The point, though, is to, do you feel like you have dyskinesia now? Okay. I'm not sure. Okay. So the point is not to hold yourself from utilizing levodopa because you're afraid of dyskinesia, but the point is to work with your doctor so that you're able to do and move, but not so much that you get dyskinesia. So remembering that dyskinesia is, and maybe I didn't say this yet, but it's having too much of the medicine in your body. And that leads to involuntary movements. And those involuntary movements can occur in any part of the body. It can occur in the head, it can occur in the arm, in a leg, it could be your torso, it could be a shoulder. Everyone is different where it starts. It could be the mouth. People feel like they're chewing on the inside of their mouth. It could be the inside of the tongue. So it can happen in various places, and it can be troublesome as well. And I'm not saying it's not a side effect that is unpleasant. However, when we know about it and we think about it and we utilize medications judiciously, we can minimize that risk by lessons learned. Next slide, please. So this is an important slide. So if you see in early PD, when a person takes, and I don't like early, moderate, and advanced, I don't like those terms, but in any event, when a person first starts taking levodopa, we call that part the honeymoon period, right? So you take your medication and you're pretty level throughout your day. You don't feel on and off and on and off. You're pretty good. You have a good response. If you have idiopathic Parkinson's, or you take your medicine and the medication works and your symptoms are pretty well controlled. But as time progresses, usually around year 5 or so, and it can be earlier than that, you have this, the timing of this window that the dark green of where the time of the symptoms working well tends to get smaller. And that has to do with a few things. It has to do with the person's gut, and we're going to get into that in a minute. And it also has to do with the buffering capacity of the neurons in your brain. So what a person may feel over time is that they'll take their medication, and their medication may take a bit longer to take an effect. So for instance, if I take it at 8 a.m., and I've been taking it for a couple of years now, I take it at 8, but it's not working until, say, 9 or 8:30 or 8:45. And it's only working for an hour and a half. And my next dose is at noon. And it works. And then around 10:30, I start to have involuntary movements. That's the dyskinesia. At the peak of the dose, I start to have involuntary movement. Then I start to have improvement of my symptoms again. And then around 11:30, my tremor or my stiffness comes back, and that's off before my next dose of medication. So we call these motor fluctuations. So you take your medicine, it takes a while to take effect. Then you have some on time, your meds work. Then there's too much. So you're dyskinetic and you have involuntary movement. Then it works again, and then you're turning off again. So this is a motor fluctuation on and off. And that's troublesome because people start to have to run their lives around these ons and off, because if you're off, you can't do the things that you want to do. And if you have too much and it's troublesome, then the dyskinesia, then that's a problem as well. So the goal is to try to keep you in that area of dark green so that you're not having this dyskinesia where when it is troublesome, it can be a big problem. There's another issue where people, like those of you, 19% of you said you're not sure if you have dyskinesia. So some people are unsure whether their involuntary movement is dyskinesia or not. And so this is an important point. And I've had patients who have had PD for a very long time, and it's very hard for them to distinguish between whether their tremor, a tremor is at rest, a rest tremor, is tremor or is it dyskinesia? And so timing in PD is everything, timing related to their medication intake. So again, if you're taking your medicine at 8 and again at 12, you have tremor and you take your medicine and it doesn't go away until 8:30 or 8:45, that's not dyskinesia, that's tremor. And then in the middle of the dose, you have some swaying movements. And again, it could be your leg, it could be jerky. That's dyskinesia in the middle of your dose. And then as it wears off, more than likely, that is tremor. But it can, yeah.
Sorry to interject. Is it important to point out here that this could vary from patient to patient?
Definitely, most definitely.
vis-a-vis dosage and on-off windows. So for some, it may be, 4 tablets a day. For others, maybe 10 tablets a day.
Oh, absolutely. Because everybody's dosing schedule is so different. Some people take it every 2 hours. Some people take 4. Yeah, absolutely. This is just an example, of course. And it does, some people don't have tremor and some people have these jerks. And so it varies very much from day to day, from person to person. Absolutely.
Sure. So a follow-up question to that would be, when people refer to off periods, are you only talking about the period where you're having dyskinesia, or it can be any time when the medicine, the dopamine, isn't optimal?
Okay, that's a great question. So off period is not dyskinesia. Off period. So Todd, can you remove the dyskinesia poll, please?
Yes.
Okay, great. So do you see down here? Oh, you can't see my slide. I mean,
Can you see my pointer? Can you see?
Yes. Okay. When you go if you see the dark green is on. Okay. But go down to the bottom. No, left. Down here. Perfect. Right here. Right there. That's where the person has taken their medication. Okay. Now, no, they're not having a response yet because they're off. So everything below that dotted line is off because their medicine hasn't kicked in yet. Then right there, that's when they start to get symptomatic relief. and they have relief up until right there. Perfect. And then right there, that's when they become dyskinetic. There you go. That's all dyskinesia right there. And then right there, the dyskinesia wears off, and then they start to be on again, right? Their symptoms are controlled, and now they start to wear off again there. And then right where it says 4 hours, that's where they take their meds again. See? So actually, if you think about it, dyskinesia is the opposite of off, because it's on, but too on.
Yeah, that does make sense. So off is really below the
Correct.
on dotted line threshold.
Correct. Right. Because if you look over to the other, the last one on that one, yes. So now people get even more off. They're good on time. That dark green is even thinner. They don't have much time. That is symptomatically good. And then they have more time spent in dyskinesia.
Right. So the $64,000 question, or the goal that you mentioned a minute ago, is how can we optimize on our own unique individual basis dosage to stay in the green as much as possible and not go above it and into dyskinesia land, and
right.
to sustain, this is the honeymoon period you mentioned is something that all of us patients would love to prolong as possible.
For sure. Absolutely. So the way, and it is the $64,000 question. So the way to do that is, and it's not foolproof. I mean, people are still going to have minor ups and downs, but the way to do that is rational polypharmacy, meaning not just using levodopa, utilizing it for sure, but not only by itself. So using it as a baseline, and then using other things with it that will prolong the dopamine or the levodopa, such as the MAOB inhibitors or a dopamine agonist, or istradefylline or apicapone, one of those, some of those other ones. And it may not just be one of them. It may be a couple of them to decrease the chances of us needing to utilize more levodopa. Now that too, since 2015, we have timed release levodopa, right? So carbidopa levodopa. We have a product called Rytari, and that actually lasts longer. And theoretically, and it hasn't been proven, but theoretically and anecdotally, I can say this in my own practice and what I've seen, is that leads to less motor fluctuations in the short term. So I can only say that since 15, I've seen that my patients have stayed on the same dosing schedule, not needing more frequent doses over time, and leading to less dyskinesia over time because of the release of it.
Is Rytari then similar to the CR levodopa that I was prescribed, for example?
So Rytari is made up of a third of the immediate release, the yellow one, and 2/3 of the controlled release, but it's in beads. And so the way that it's delivered is different. So you can't just take like an IR and a CR and it won't work the same way. The way that it's delivered is different. Okay. And then there's also, so that's one thing. And then I'll get to another thing in a minute, but yeah.
Okay. Let me just chime in for a second administratively here. I see that Ava has raised her hand. If anybody wants to use the raise your hand tool, it's harder for us to use and respond to that right now. Please put your questions into the Q&A tool at the bottom of your Zoom tray. Okay, carry on, Dr. Salima.
Okay, so next slide. So I hope that dyskinesia, the term dyskinesia, and I hope that's clear now. And so this is important. This is an important slide because this is part of the problem in PD, and what leads to some of these motor fluctuations is that levodopa is absorbed in the small intestine. And so this shows an immediate release Sinemet in the stomach. So an hour and a half after the person took it. So it needs to get to the small intestine to be absorbed. Well, for those of you who have PD and you took your medicine and an hour and a half ago and it's sitting in the stomach, but it's got to get to the small intestine to be absorbed into the blood and get to your brain, it's no wonder why you're off, right? And then once it does get, it can lead to dyskinesia because then it's kind of like a traffic jam. So, you know, when you're at a traffic jam and then all of a sudden the floodgates open, and that can lead to dyskinesia. That's how I think of it. So there's a lot of issues with the gut in people with Parkinson's because there's dysmotility, there's gastric emptying issues, the gut is slower in PD. And so those problems lead also to issues with the absorption of the medication as well, and dyskinesia.
And can you tell us about any tricks to ensure that we get the levodopa into the intestinal lining? Like somebody told me they're using vitamin C together with your Sinemet.
So drinking water, yes, historically they said orange juice, things like that, carbonation, but you know, keeping constipation at bay is a very, very important thing. So you know, so many people have constipation and PD, but making sure that your bowels are moving, that will also help the absorption. And you know, we all have bacterias in our gut, and so if there's a small bacterial overgrowth, that could be checked. And if you do have a small bacterial overgrowth, that you can be prescribed an antibiotic to have that eradicated. That can come back, but having that taken care of can help the absorption of your medications as well.
Okay.
Next slide. So what we were talking about in terms of what can be done for dyskinesia. So minimizing the high doses of levodopa. We don't want you not to use it. We just don't want people taking, 4 tablets 3 or 4 times a day, because that's going to lead to dyskinesia in the future. Rational polypharmacy. So what does that mean? Using a little bit of this, a little bit of that, and a little bit of this, a little bit of an MAOB inhibitor, a little bit of levodopa, and a little bit of either a dopamine agonist or some other baseline medication. And remembering that we have on-demand medications too. So if you run in a bind every now and again, we don't have to automatically increase your levodopa. We can use something that you need. If you have, every now and again, you have a little bit of wearing off, it doesn't mean the knee-jerk reaction shouldn't be, well, let me just throw more medicine at you. You can use something on demand. Controlling constipation, as I just mentioned, as well as bacterial overgrowth. And then amantadine products. So amantadine has been around forever and a day, since the 70s. So that can help with dyskinesia. And then there's a product called GoCovery that's been around for a few years now, and that really helps dyskinesia and also helps off periods. It's a really good medication to help both. And then for those of you who have a lot of dyskinesia, who have perhaps been on levodopa for, a decade, 2 decades now, and the dyskinesia is quite troublesome. One can have DBS, of course, and then there's also Duopa. And Duopa is an intestinal gel of carbidopa levodopa, and it's through a tube, and it's connected to a pump, and it goes it's delivered right into the small intestine. So it bypasses the whole GI system. You don't have to take oral levodopa, and that will minimize as well the dyskinesia. Next.
Interesting.
Dr. Brillman, can you repeat the name of the medicine that you said after amantadine?
Sure. After amantadine, GoCovery. GoCovery is an extended release amantadine.
Okay, thank you.
Mm-hmm, sure. So what should I do? Should I avoid treatment with levodopa in order to stave off dyskinesia? Absolutely not. I hope if you take anything away from this, please don't hold off on using levodopa. That's not the answer. What we hope you do is you work with your healthcare provider to find the treatment regimen for you that will keep you level, and it can be done. Now, am I going to say you're going to be like this? No, because there's changes. There's changes in the brain, there's changes in the gut, but it can be done. And we want you to have a good quality of life now and be the best you can be. And we have lots of tools right now. I mean, this is not the PD of 15 years ago. This is a totally new landscape that we have with these symptomatic treatments. So I encourage you to be active and advocate for yourselves, because you are really good advocates, and ask your doctors about what there is out there. Next. So what can dyskinesia affect? And it can, when it's troublesome, it can be very troublesome. Dressing can be affected. You may need help getting dressed. Eating is a problem and can be a problem. It can, I've had patients tell me the plates are flying all over the place. Red wine is everywhere. Socializing, it can be very, very embarrassing. It can cause problems with swallowing and speech as well. So people find it really hard to understand their loved ones when they're very dyskinetic, and it can cause pain. So if a person is constantly moving, I've had patients who have come to me and they've had, bulging discs in their back, or they've had hip problems because of the constant movement. It's a constant movement. Dyskinesia can be. So it's not something that should just be ignored, or it'll go away. It needs to be addressed. And I say this every single time I speak to a group of people with Parkinson's. You guys are the most stoic people I have ever met. Nobody complains, but it's not a complaint. You need to bring it to the attention of your healthcare providers, because lots of things can be done. So yeah, swallowing, and that's a problem too, because swallowing can lead to aspiration, which can lead to an aspiration pneumonia. And we don't want that. Pain, socializing. And that's the other thing, it's important. We want people to be social and to live their lives, and eating, walking. Yeah. People are often mortified because they feel like they look like they're drunk. They may bash into a wall. So we don't want any of those kinds of things happening. So,
and you're right, speech should be included in that list eventually.
Yes, definitely. Next. So, and then as we talked about motor fluctuations, right? So the dyskinesia, that can lead to falls, imbalance, people thinking that you're drunk, knocking into walls and tables, spilling things. And then of course, on the other end of the spectrum, people freezing of gait, and you'll see that as fog coming up afterwards. People fall, they may have festination, little tiny steps, problems turning, and then initiation of gait upon standing up from a chair. And all of these can lead to falls. And that's another problem that we don't want for our patients, because falls can lead to fractures, and God forbid, we don't want any of that. So next. So how does Parkinson's affect gait? So, for those of you who have it or are around people with PD, it is a distinct gait. There's a change in posture. People start to get stooped. There's slowness. There are shorter strides. People tend to have their head, dropped a bit. They may lean to one side. They may drag one leg particularly. They may shuffle. And then everything is smaller in PD. And so their stride length is smaller. There's a reduced arm swing, which is why your doctor tells you to walk down the hall looking for that as well. So these things are important, and they're important to tackle. And particularly well, all of it, but the change in posture is important. How you struggle with gait issues some of the time. Okay. And then some people are all the time. The change in posture can lead to a change in your center of gravity, which then can lead to balance issues and falls. So super important to get that better, working with physical therapy and such, range of motion and things like that. Next. So as I had mentioned, freezing of gait. So for those of you who have it, you know exactly what it is. It's you just stop for no good reason. You want to keep going, but your feet don't. So you stop. And that's also precipitated by small areas. It could be through a door, through an elevator. And you may take little tiny steps. And this gets worse when people are not active. So, you know, we sound like a broken record, but it's really very important to keep active in this disease. It's vitally important. And the reduction of activity leads to loss of muscle strength and decreased reflexes. And so if you're stooped and your center of gravity changes, and then you're leading to the about to fall, you can't catch yourself as quickly, and that becomes a problem as well. And then fear of falling becomes a problem because once a person has fall, they're afraid of doing so. And then this leads into a snowball effect of, I don't want to go out, I'm just going to stay at home. And then people's worlds get smaller and smaller, and that's not what we want, particularly coming out of a pandemic. Next. Sure. So what other things can cause gait problems? So wearing off, we talked about that, right? So that's more in the fog and freezing of gait and festination and things like that. Dyskinesia, as we talked about, that can lead to gait problems. And then NOH. So NOH is neurogenic orthostatic hypotension. And that is something that happens in people that, in about 25% of people with Parkinson's. And what that is a drop in blood pressure when a person goes from a sitting to a standing position. Sometimes it's not just when you initially stand, but it can be after you've stood and walked for a little bit, or if you're at the grocery store and you're standing and you feel like your legs are going to give way, or you feel like you're going to fall into a black hole. So these kinds of things can be related to blood pressure with Parkinson's. So what do we want to do in treating these gait issues? So physical therapy is vitally important as well. A lot of my patients say, I don't feel like doing it. It's not important. It really, really is. It changes it rewires your brain to think in bigger, it retrains your brain to think in bigger steps and bigger ways, bigger strides. So it's super important. And the funny thing is that many people with PD think they're walking straight and their posture is straight and that they're taking big strides, but in actuality, they're not. So it's really important, that repetition. Being aware of your posture is important. And avoid multitasking. So lots of people want to like hold a bag and hold a cup of coffee and this kind of thing. And that will lead to problems and falling. So I encourage you not to try to multitask as you're walking, because that can lead to problems. And then using visual cues and auditory cues. So if you do have the freezing of gait, marching or listening to 1, 2, 3, 1, 2, 3, as well as lines on the ground. So if you're the type of person who freezes when you go into the restroom or to your closet, you may want to put on a piece of darker tape, like blue tape, on the ground, and that will initiate your brain to step over that threshold and make it easier for you to get through. And stretching daily is super important to keep those reflexes.
So, Dr. Brillman, I haven't suffered yet from freeze of gait. Is it something that afflicts us in the same location, for example, around the house at a particular door threshold, or always with elevators, or does it vary from?
No, it varies from person to person, and not everybody gets it, but it can be common, and it depends on the person.
And so the colored tape you're suggesting on a door threshold, for example, is basically something for the brain to focus on that wouldn't be freezing of gait.
So in a person who does have freezing of gait and you put that on over the threshold, that's a sensory cue for your foot to go over it. Or if you're with a loved one and they put their foot in front of yours, that would be a sensory cue for for your foot to go over it. It's amazing. They even have laser canes so that when you put the cane down, a laser light comes right across, and that's a sensory cue for your foot to initiate the movement.
Interesting. That's probably where physical therapy becomes very helpful. That's where they start to train you for those sensory reactions.
Absolutely. Absolutely.
Great. Okay. That brings us to the end.
Okay, great. Sorry, I think I talked a lot, but hopefully we've got some questions.
Oh, we do.
I just put a link in the chat to one of those canes, the Get Next Strides cane that you just referred to.
Oh, great. Yeah, they are very helpful. And usually people with PD, you can see them across the room because they hold their cane up. They don't actually use them, but they're very helpful for the laser. Yeah.
Great.
Yes,
Okay, let's
there's
dive
a
into
lot of questions in the chat.
Yeah, why don't you start, Monique, and then I'll follow you.
Okay, so let's keep on with the gait conversation, because I think that's really interesting. One person is asking about, can gait issues ultimately result in chronic back pain and hip pain and other problems with your body?
Absolutely. So that's a great question. So gait issues can, and so can, if a person is compensating for something, if either it's their foot, let's say their foot is dystonic, or they have a back, their back hurts or their hip hurts, and they start to compensate for that, then they might wind up with other orthopedic issues. So it's very important that you talk to your doctor about whatever is ailing you in the orthopedic realm. The same is true with knee problems. So a lot of people, as we get older, our joints are starting to become an issue, and then we compensate for the other side, and this becomes a problem for the rest of the skeleton. So it's super important to get these things looked at and taken care of if possible.
Okay. Carrie asks, what have you learned about the interaction between PD and cold weather? My PD gets much worse in weather colder than 60 degrees. And thank you, she says.
Well, that's a great question. I think that's really, it depends on the person. There's some people that do really not so great in heat, and their tremor gets worse in heat, and then some people are worse in cold. So it's really variable in terms of the temperature. I would say if you get worse in cold, then try to keep yourself as warm as possible and not live back east. That's for sure, but
you can avoid it.
Yeah.
Are there particular exercise regimes that you recommend or that are recommended for gait, to improve gait? Is walking enough, or do you really need to sort of do more than that?
Walking, stretching is very, very important. And retraining the brain is really important with physical therapy. So there's power, there's LSVT, those kinds of things. But anything that you're gonna, and also utilizing those sensory tricks, as well as the modalities, the auditory tricks and there's lots of them online too that one can get. The 1, 2, 3, the music, those kinds of things that can help to keep you moving as you're walking, to not have, if it's freezing of gait, is what I'm trying to say.
And is there any particular exercises or stretches rather that you could recommend? Somebody just asked about that, stretches.
Not particular ones that I know of. No, just basic ones. I do know that in certain studies, Tai Chi has been the one that's been the best for gait, though.
I'll also share my own little silly mantra that I use when I'm on my power walks with my wife, which is swing, swing, heel toe, long strides upright. And I chant that to myself anytime my left arm stops swinging or my gait or my feet shuffle instead of going heel to toe.
Yeah,
Not standing straight up enough. So
that's great.
So repeat that mantra then for us,
swing,
Todd.
swing, heel, toe, long strides, upright. Silly, huh?
No, it's not, because things aren't automatic. And so you have to just keep repeating it. Otherwise, it's not gonna happen. You got to keep doing it. So
I don't do that, 100% of the walk. We fall into conversation with my wife, and then I realize that my left arm's not swinging, or my shoulders are just tipped over, or, one of my usual 4 problems with gait. And so I chant that to myself for a few strides and get back into
gets
shape.
it going. Mm-hmm.
That's great. When you talked about the dyskinesia as being levodopa induced dyskinesia, are there other types of dyskinesia that aren't induced by levodopa?
Yes, but not in PD. So you may have heard of tardive dyskinesia. So that happens when people are exposed to antipsychotic medications and things like that.
Mm-hmm.
Let's see. Rick asks, how does dystonia fit into this equation? Namely, is there a direct or indirect relationship between dyskinesia and dystonia?
So dystonia is not uncommon in people that are young onset.
Why don't you start by telling us what dystonia is?
Oh, sorry. Okay, so dystonia is sort of, it's a pulling of the muscles, both the antagonistic and agonistic muscles of one of the limbs. So it can be an arm, it can be the foot, it can be the feet, it can be the neck. And so typically people may feel in the middle of the night or the early morning, they may feel like their toes are curling or cramping, or they may assume a posture like their arm is sort of going in this way. So those are the kinds of dystonic posturing. Some people you may see have their neck assumes a certain position. So that's dystonia. It's an involuntary movement, but it's not an involuntary movement like dyskinesia, which is sort of a dance-like movement. It's more of a posturing. So it doesn't move. It's stiff.
And is there any relationship between the two? And
it's the opposite spectrum. So it needs more dopamine.
Okay, good to know.
Going back to sort of increasing the uptake of the levodopa in the gut, you talked about constipation as being, particularly problematic. A couple of people have asked about, specific ways to sort of increase the motility of the gut. For example, drinking lots of water, taking psyllium husk, with when you take your medicine. And so I'm wondering if you have any specific thoughts on that. And then sort of related, well, why don't we start with that?
So definitely drinking lots of water is extremely important. Exercise is very, very important. I recommend my patients to take probiotics, and then greens, leafy greens. So you could have like a smoothie with leafy greens. Medications that have a lot of fiber can be bulking. Bulking agents aren't typically great for people with Parkinson's because they can cause more on the opposite side, on the constipation side, rather than relieving it. Miralax is a medication that's good in people with PD because it pulls water from the intestinal wall and helps to help with the bowels. And let's see here. And then some people, we want people to have, the goal is to have a bowel movement at least every other day. People can really get into some trouble and get into, you know, 3, 4, 5 days, even longer, and then wind up having, you know, impactions and then wind up in the hospital. And as you know, the last place on earth we want anybody is the hospital. So it's really important to stay on top of the bowels. Yeah.
And how does one test if you're interested in, you know, testing for bacterial overgrowth in one's gut? Is that something that you would ask your primary care doctor to test for?
Yeah, it's usually done by a gastroenterologist, and it can be done via a breath test. So they can, yeah, they do it via breath test. And you know, you do have to follow certain things, like you can't take a proton pump inhibitor for like a week and this, that, and the other, but it's a pretty simple test. And they can also check for H. pylori as well, which can interfere too with absorption. But small bowel, I'm sorry.
And do you know anything about the effectiveness of the fecal microbial transplants?
I don't.
Somebody was asking that question, sort of related.
Interesting. Okay, let's see. Annie asks, can you please address when to take Cinemet and when to eat proteins?
That's the question of the hour. So I'll tell you. So it really depends on how early if you've been just diagnosed. Well, okay, let me start with, I don't like stepping on doctors' toes, but I'll just give you my opinion. When a person is just diagnosed with PD, I typically say take it breakfast, lunch, and dinner. And I don't, because I think it's really hard for people who have just been diagnosed. They are typically super healthy. They've not even taken an aspirin. And here I am telling them to take three pills a day. But not just that, the absorption issue is really a small issue, particularly at the beginning of the disease. But as time progresses, there is competition of absorption between protein and levodopa. And people will start to recognize it. So when that happens, that's when we have to start to make adjustments. Yes. But I don't recommend it at the outset. No.
Okay.
How will people recognize it? Sorry, Todd.
Go ahead.
They'll notice that their medicines aren't working after they've eaten a hamburger or a steak. And that's when I say, okay, well, then we need to start to, you know, make it so that you eat before or hold the medicine, etc. But it's quite evident. Yeah.
But you mentioned a minute ago that your first line of recommendation might be 1 pill per meal. So is it recommended that we take our meds at mealtime or before or after, given the fact that we wanted to get into our intestinal lining?
So I usually do breakfast, lunch, and dinner, and I say just take it with. So whether you take it right after, you know, but the key is take it with a lot of water.
Okay, good. That was another question that knocks that one off the list. What are your thoughts? This is from Carrie again. What are your thoughts? Maybe I shouldn't have told her the name. What are your thoughts about THC and PD? Smoking THC has been great for my muscle rigidity and pain. However, I worry about any long-term negative impacts.
So THC, I don't recommend THC because of the hallucinogenic component. So that CBD without THC is one thing. But because of the hallucinogenic and the memory issues that can occur in the long term or even in the short term, I ask my patients to steer clear from the THC.
And that doesn't speak directly to our topics anyway, but I thought it was worth throwing out there.
Yeah.
Monique, have you seen anything?
Yeah, so Deborah asks about, she had DBS in June, and she says she had great results, but there's definitely a lurching walk almost all the time. And she was wondering if that was dyskinesia or if that could be something else.
It could, I guess, a lurching walk. Can we, does she mean like it's her legs flinging out?
I'm
No,
not sure.
I know. It may be, it can. I mean,
it sounds like she thinks it might be dyskinesia, and she's saying she didn't know that that was dyskinesia. So
it's a possibility,
Mm-hmm.
so she should speak to her her doctor about that and see if that can be changed. Her settings may be decreased or something.
Mm-hmm. Yeah, she says lurching walk. She looks like she's drunk.
Oh, it's a possibility that it's dyskinesia. Yeah.
Mm-hmm. Thank you, Deborah, for clarifying that.
Thank you.
Dr. Brillman, Linda asks, back to walking, would walking with walking sticks be helpful or considered multitasking and risky?
No, they're not considered multitasking. That's a good thing. Walking sticks are good.
Generator, right?
Exactly. Yes.
In fact, it would help me because it would keep my arm swinging when it doesn't.
Exactly correct. Yes, I think they're very good. And also I think they're good because they keep your posture up as well. So I think it's a very good thing to use.
Yeah, you see them more and more out there. I mean, they started becoming popular in the hiking dimension, but I see them more and more around the sidewalks too.
Yeah.
Here's an interesting question, because you talked about dyskinesia happening when you sort of have you're at the peak of your dose and you have too much dopamine. So someone's asking that if you're having in the middle of a dyskinesia episode, might you eat a little bit of protein to help with that? And I think that the reason that the protein interferes with the medication is that it's sort of absorbing. How does the protein and the medication affect? And would that be helpful?
I think by the time the protein got down there to help with decreasing the dyskinesia, I mean, I think it just depends. I don't know how long it would take for the protein to get down there to make any effect on the dyskinesia.
Yeah, maybe this person could try it and see if it works.
Yes.
I mean, I think it's such a unique situation. It seems like it varies by everybody. So maybe
it really does. And everybody's transit time, GI transit time, is so variable. So it's hard to know. But I mean, certainly, that wouldn't hurt. I don't think so. Yeah.
Especially since the gut slows down with folks with PD, right?
Oh yes, it sure does. Yeah, at the PI we did gut transit time studies, and it was amazing. I mean, one person was like 41 hours, and so it's amazing. And he never had any effects. He didn't feel anything, but it does slow down for sure.
So on that note, and this is not necessarily a question from our attendees, but there are supplements out there to help expedite metabolism. Would you say those are good for us or not?
I think I would want to see what those supplements had, just to make sure that they didn't have any interactions with any of your meds or anything to that effect. Yeah.
Okay. So maybe check with your healthcare provider in that case.
Definitely. Mm-hmm.
Gregory asks, what other meds out there besides amantadine might help treat dyskinesia?
So,
other than decreasing Cinemet, I mean.
And honestly, we've done, there've been studies that even decreasing the Cinemet isn't really the answer either, because people will still have some dyskinesia but they'll depending on how long they've been on Cinemet and how long they've had PD. So that's usually not the answer either. And then their symptoms get worse because they're stiffer or they're slower. So that's really not the answer either. So other things that one could do is changing over to a longer acting, like to a Rytari, if you're on an immediate release Cinemet. That'd be something that one could do. anything longer acting is going to lead to better, translate to more to a better, smoother day. So for instance, if you're taking immediate release dopamine agonists or immediate release Cinemet, utilizing a longer acting anything is going to make things smoother for you. So it's hard, it's hard to know what everybody's on, but if you can't tolerate amantadine, that, Rytari would be a good thing for someone. And then there's Duopa. If you're up and down all day long, that's another option. DBS is an option.
One person's asking about amantadine and psychiatric disorders. It sounds like this sort of exacerbated some sort of mental illness. And do you have any thoughts on that? Is that a sort of contraindication of taking amantadine having mental illness?
So amantadine can precipitate hallucinations in some people. So if a person has hallucinations to begin with PD, I would be very cautious in prescribing them an amantadine product. Yeah.
Okay. It sounds like somebody else is commenting that amantadine caused skin discoloration.
Yeah, it can cause a benign skin discoloration, but that it's usually of the legs. It can also cause swelling of the lower extremities as well. So things like that your doctor should go over the side effect profile. Again, it's not in everybody. It's probably in less than 15%. But it can happen, yes.
And that's a good question in terms of managing all the medications. There's lots of medications that we talked about today. I imagine this is through your neurologist or your movement disorder specialist and not your primary care doctor. Is that right?
Yes, definitely. I would think so. I mean, I think it also depends on where a person lives. Here in our area, it would be the neurologist or the movement disorder neurologist. Yes.
Well, and that leads me to another question, which is that when we spoke before the talk, you had mentioned that you were doing some work trying to sort of increase access to movement disorder specialists. You had mentioned that there was sort of a lack of movement disorder specialists in some sort of rural areas. And so can you speak a little bit about your work in that regard and how the change in telehealth, as a result of the pandemic, where a lot of people who are doing advocacy work are trying to increase telehealth and sort of how that plays in with your efforts as well?
Yeah, sure. So, my colleague and I, who lives down south, she and I, for years prior to the pandemic, we've been around the country, and we noticed that there's a lot of places in rural areas, even rural California, that don't have access to movement disorder neurologists, and so their PD looks a little different than others, and so we decided and had wanted for a long time to get a platform where people could have access to movement disorder neurologists via telemed. And so we're in the process and very close to accomplishing that dream and goal. So that people can have access to us and have appointments, and we can help them and collaborate with their own neurologists, but at least have access to, more newer medications and things that can help them get medications that might be able to translate into more of a smoother day for them, and maybe not so much in the way of, motor fluctuations and things like that.
And so how does that translating into sort of the real world? Like, how are you actually improving access? Are you making these services available online for free? Like, how does it?
No, it's not. Unfortunately, it's not free. I wish it could be. It's not free. So we have a website, and then via the website, a person can make an appointment to see us, and then we would see them like you would see any doctor via telemed. It's just so that because we can't be everywhere, we could have an appointment with them, and then we could go over their medications, and they could tell us what their problems are. Is it dyskinesia? Is it falling? Is it this, that, or the other? Do our UPDRS, Unified Parkinson's Disease Rating Scale, go through the motor and the non-motor symptoms and see how we can make things better for you. Are you sleeping? You know, do you have depression? Do you have constipation? Helping navigate through all those, and then, you know, changing the medications to see what we can do to make that better and translate into a better day-to-day for you and your care partner, because this really is something that affects the whole entire family. So
that's great. That's really
Mention
admirable.
website. Can we publish that now where folks can learn more about your telemedicine and your accessibility?
Sure. It's BB Telemed.
BB like boy.
Yep. Like Brillman and Bixby. bbtelemed.com.
bbtelemed.com. Got it. Okay. My one-handed typing is very slow. Okay, great. We talked a minute ago about dystonia and its relationship to dyskinesia. Sally asked, when does one get dystonia? I mean, what are some of the causes of dystonia?
Some people never do, but some people will get it when their medications are wearing off. And some people, it's more common in the younger patients, but even older patients will get it. But it usually happens when people are wearing off, when their medicines are wearing off. And it can be very painful. And it usually affects a limb. So their foot, their hand, that kind of thing.
Okay. Let's see, let me try Mike asking about Rytari. If you are taking too high of a dose, well, if you're taking a high dose of Rytari, so for him, for example, it's 4 pills 4 times a day, which is causing dyskinesia, can you back off to a lower dose, and what might withdrawal symptoms be like?
So Rytari is, in my opinion, a really good product because it comes in 4 different doses. So one can really dial it in. So yes, you could decrease the dose depending on whether it's too high, is it lasting long enough, etc. And you wouldn't have withdrawals, because I would hope nobody would just stop you cold turkey, but slowly wean it down depending on when your dyskinesia is. That's what I tend to do. I ask my patient, well, are you dyskinetic at this time or this time? And people tend to stack. So the levodopa tends to stack as the day progresses, and they tend to get more dyskinetic as the day later in the day. So I typically, this is how I practice. I typically take off a little bit in the afternoon, leaving the morning the way it is. So everyone's different, but yeah, you wouldn't have a withdrawal if someone did it. Yeah.
Good. Helpful.
Here's a question about vascular Parkinson's. Says, what treatments are available to those with vascular Parkinson's for dyskinesia?
It would be the same. It would be the same treatments.
Okay.
Brian asks, what effect does levodopa have on B12? Or maybe more directly, what good does B12 do for us in terms of gait and dyskinesia?
Okay, well, B12 is really important, and everybody should have a B12 checked. And when your doctor says your B12 is normal, ask what that level is, because the lab level of normal is usually in like 225 or something to that effect to 900 something. For neurology, we want a level greater than 600 or 700. If your B12 is normal, but it's 250, that's still very low. And B12 is important for balance. It's important for memory. If you have numbness and tingling, that kind of thing in your feet, your hands, it could be from B12 deficiency. So B12 is an important thing to get checked. And and to make sure that you don't just hear it's normal.
Right. And maybe don't just blindly go out to the drugstore and get B12 if you don't know what your current levels are.
Correct. And the other thing is the absorption. So if you are told that it's low and you need to take it, it's better to take a sublingual B12 than just a pill, because of the absorption is better when it's given sublingually.
Okay. Good. Well, we're a little bit less than 10 minutes away from a wrap here at 12:30, but we've got a few more questions. So if you're okay,
Sure.
we'll talk through a few more and then wrap it up.
Okay.
Monique, do you have anything at the top?
Well, I wanted to share a comment from one of our listeners who said that I learned to live with my dyskinesia by holding my breath when I need to do something, for example, like thread a needle, and also by reassuring people around me that